Hello, my name is Brian Distelberg. I'm a professor in the School of Behavioral Science at Loma Linda University and the Director of Research for the Loma Linda University Behavioral Medicine Center here in Southern California. This video abstract will present our recent article published in the Journal of Family Process. The article is entitled Evaluation of Healthcare Cost Offsets of MEND, a Family Systems Mental Health Integration Approach. On behalf of myself and my co-authors of this paper, Dr. Marjorie Castronova, Dr. Daniel Tapanes, Jesse Allen, and Dr. David Puder, we thank you for your interest in this work. Behavioral and physical health integration has been shown to be beneficial for overall health outcomes as well as financial benefits. There's a wealth of empirical studies supporting the improved outcomes associated with integrated healthcare. To date, there's been numerous individual cost-benefit analysis studies, as well as meta-analysis and longitudinal studies showing at a minimum a break-even outcome associated with healthcare systems that provide integrated behavioral and physical healthcare services. Because our United States healthcare systems are not truly integrated yet, there are significant costs incurred by systems that seek to provide integrated care. Also, most third-party payers do not currently reimburse fully for this type of care. For our study, we were interested in the financial benefits produced by patients who had both behavioral and physical health diagnoses, who also had received integrated care. To study this question, we examined the MEND model. This family systems biopsychosocial model was developed in 2009 specifically for individuals who have physical chronic illnesses. This family systems approach offers individual, group, family, and multifamily therapy techniques, which are delivered in a multidisciplinary team. In previous MEND studies, MEND was found to produce significant health benefits such as health-related quality of life, reduction of biological stress, improved academic performance, improved work performance, and furthermore in 2016 we conducted a smaller cost-benefit analysis study of the MEND program with youth patients. This study showed a significant cost benefit for insurance providers and healthcare systems. In our current study, we evaluated the MEND program cost offsets with our adult population. This study utilized a larger sample, which allowed for a more robust and complex model estimation, as well as measuring a longer time frame for healthcare cost offsets. In this current study, we assessed patient medical records and billing information for patients that were served at the Loma Linda University Medical Center. In addition to being healthcare patients within the university hospital and clinics, these patients were referred to and admitted to the MEND program. This program is delivered at the Loma Linda University Behavioral Medicine Center, and MEND is offered at a partial hospitalization and intensive outpatient level of care. 107 patients' data were available and met the inclusion criteria for this study, and these patients had been referred to MEND from either a primary care or specialty care physician. All patients had incurred physical health care costs with 12 months prior to admission to the MEND program, and less than 50% had additional behavioral health care costs. 73% of these patients had significant financial health care costs 12 months prior to admission, and therefore were categorized as medical patients for analysis in this study. The remaining 16% had minimal physical health care costs but significant behavioral health care costs and were categorized as behavioral health patients. The majority of patients met the inclusion criteria for both physical and behavioral health care costs and were categorized for both in the analysis. For this analysis, we measured the patients' incurred healthcare costs 12 months prior to MEND, 12 months post-MEND. We also measured the number of MEND sessions received and the cost of each session billed. In addition to that, we measured numerous demographic variables available in the medical records, such as the patient's sex, marital status, age, race, ethnicity, insurance type as a proxy for socioeconomic status and level of education. A series of pre and post t-tests were performed first, and then a multivariate hierarchical linear regression model with distinct behavioral, physical, and total healthcare costs was assessed as a multivariate outcome. The overall findings suggest that this family systems interdisciplinary approach significantly reduced healthcare costs. In total, our model estimated that with each additional MEND session, post-healthcare costs reduced by $1,169. This works out to a 12-month average reduction of $16,376 per patient. Given that the program averaged a cost of $7,125 for each patient, the overall net savings per patient for a full year was $9,251. Although reductions were significant for both physical and behavioral health care costs, physical health care costs were reduced by 53.6% 12 months after the program, and behavioral health care costs were reduced by 23% over 12 months post-MEND. Controlling for demographic variables, especially those associated with economic status, was crucial, as healthcare costs in our sample varied significantly by these factors, and these findings paralleled similar outcomes seen in health disparities literature. We hope the study offers further guidance in a changing world of healthcare. We also hope that the study shows the benefits of employing a family systems approach for patients who have both physical as well as psychosocial needs. I encourage you to read the paper and contact us with any questions. Thank you for your time.